And I'm just going to point to my experience with the study that I am the PI of, LU002, to give you a sense of where we are, where we need to be, and how we can, improve on what we've done. And so this is, as you would imagine, with a treatment option, local therapy, synergized with systemic therapy. It's a large team made up of medical oncologists, radiation oncologists, surgeons. It's the entire multidisciplinary team that's really critical for assessing when local therapies may be of benefit. But the idea is as similar to the early phase 2 studies. So we take patients with metastatic non-small cell lung cancer, give them systemic therapy. It can be immunotherapy, it could be chemotherapy, it could be combination therapy. And then after 4 courses, we make sure that there's no progression, and we make sure that the patients have 3 or fewer sites of metastatic disease beyond the brain. And then we randomize them to either maintenance systemic therapy alone, so they just continue systemic therapy, or local therapy in the form of radiation and surgery to the Mets, followed by maintenance systemic therapy. And the real question we want to understand is the addition of local therapy going to improve survival outcomes? And so this is a phase 2/3 study, which means that we've enrolled 218 out of 378 patients. And the idea is that at this moment in time, we are going to do a check to make sure that we still have a progression-free survival signal, and if we do, then we will move on to the phase 3 portion. What's critical, because I'm a big harper about biology, is that we've collected samples at registration, which is after the induction systemic therapy, after the local therapy for that arm of the study, and at first recurrence. We'll really be able to try to understand systemically what's going on as a function of what's going on with respect to imaging and other tools to aid us determine outcomes. This study allows all forms of FDA-approved systemic therapy regimens, but it's really become a immunotherapy trial. At this slide says 80%, but at this time, more than 90% of the patients have received IO or immunotherapy-based systemic therapy. So it's really a question of whether local therapy helps immunotherapy improve our treatment outcomes. Why is it really important to finish that study? Because we had some parallel sister studies, one going on in the UK, which was going to be a very important study, headlined or PI'd by my colleague, Dr. McDonald. Unfortunately, because of poor enrollment, they had to drop going from a phase 3, and now it's really a phase 2 trial. So it goes back and answers the same questions that is the same level of questions that the original studies answered. And we really need to answer this with a larger patient population. And so, we do have other studies. Omega's a similar study out of Italy. There's a study out of India looking at similar questions, but we need to complete them. The thing is, we need to complete them in a timely fashion. But it's not so simple, because as systemic therapy gets better and better, there are newer and newer first-line regimens. So we need to incorporate and account for them as we do these trials. But the real questions that are relevant to patients and the physician teams are: what if we don't have an overall survival benefit, but the progression-free survival benefit is significant? We also, mind you, have very important quality of life metrics built into these studies to better understand, how quality of life changes are occurring over the course of time. What if quality of life is very significantly improved, but the PFS benefit is limited, the OS benefit is limited? These are all the types of questions that we have to ask. And at the end of the day, as I've said, we are going to anticipate doing a lot of biology on this trial, trying to collect the blood specimens to understand how the immune system is responding to the local therapies and how there may be a synergy between local and systemic therapies. We're doing radiomics to try to understand how imaging may help us predict which patients may benefit from local therapies. But again, we need to develop a greater insight and have a greater level of urgency with these trials. And I think at the end of the day, doing the phase 3 trials as a confirmatory approach is very good. But what we need to continue to do is early phase trials that give us a better biologic understanding of which patients may benefit from these treatments and which patients will not. Then by doing this, we can enrich through a biologic approach and through biomarkers, these phase 3 studies to increase the likelihood that these studies will actually give us a very strong positive reading. To that end, our systemic therapy colleagues and medical oncology colleagues have done a wonderful job of doing these basket and umbrella trials to try to capture as many patients as possible and use a standard platform to ask a number of clinical questions in a more urgent and rapid manner. I think the same can be done with systemic therapy combinations with radiation therapy as a local treatment. To answer some of the questions that I described before were unanswered, and also to get, to give us more understanding of the biology, which may inform us on the larger scale clinical trials. And so, with the right samples collected, with the right biologic questions answered, we really will be able to help understand why there are outliers in the process, why there's heterogeneity in our clinical findings. And I think that's as important as getting the right results from the trials.